actually is also very nice to speak about a topic that I think is extremely important. I cannot promise you now that you will go home with a recipe. Yeah, but I hope that we at least can discuss certain topics and also, get you thinking about what we can all do to prevent Alzheimer's disease. First, just to get a little bit, why would we want to prevent Alzheimer's disease? And I think that answer is actually given from, and I don't know, maybe some of you are familiar with this series of self-portraits from the artist William Utermohlen, who actually was born in 1933, moved to here in the US, moved to Europe, and throughout his career painted self-portraits. And he continued painting self-portraits when he developed Alzheimer's disease. And this is a portrait in 1996, and I'll just walk you through the stages of his disease. And you see the years on the right. And that is the last portrait that is known from him, and he died a few years later. And I think this is really why we think we want to prevent that disease. And it's becoming more and more of a problem because, as you know, the good news over the last 2 centuries is that people live longer. And the life expectancy is increasing even now as we speak. But dementia increases with age, and that of course means that more and more people will develop the disease over the years to come. And that is presented in these projections. These are the number of people suffering from dementia at this moment, or actually in 2010 in several parts of the world. And these are the projected increases in numbers of people suffering from dementia. You see, this is a dramatic increase in the years to come. If we look at it in a proportion, this is absolute numbers, then in the next 1.5 decades, there will be a 50% increase in Western Europe and North America, 100% increase in other parts of the world. But in the years that come thereafter, actually that increase may be even bigger, up to 400, 500% are current estimates. So we definitely have to find ways to prevent Alzheimer's disease, to prevent dementia. Before I get to that, maybe some basic concepts. What are we talking about, or what is important to realize when we talk about prevention of diseases in general? First, this idea, what are we talking about when we talk about health? Because that is actually also in an aging society, I think it's changing a bit. We are used to this old definition from the WHO that described health as a sort of near perfect state. And I think that is something where in more recent years people have said, well, we have to adapt that a little bit, because maybe health in an aging population is not if people are perfectly healthy, but actually more important is whether they can cope with the situation in which they are. If there are limitations in their physical or mental abilities, can they deal with that? And can they adapt to changing societal demands? And I think that is an important thing to realize if we talk about prevention of disease. Another concept is risk. If I say we will die 100%, all of us, that is absolutely true. Yeah? But that's basically because I did not specify when that will happen. Time is an important component if you talk about risk. If we talk about dementia and Alzheimer's disease, how we are sitting here, we have a pretty high risk, 30%. 1 in 3 of us will develop dementia. But then, of course, it makes a big difference if we develop dementia in the next year or 30 or 40 years from now, right? And that actually is very important if we think about prevention of age-related diseases. It may actually be not so much whether we can completely annihilate the disease, but actually if we can postpone the onset, if we can push it towards the end of life, or even better, towards the afterlife, then we would have compressed morbidity. And this afterlife actually is not a bad idea, because Who cares? Yeah? Prevention works. And there are a few things to also realize about prevention. And first is that one need not always know what the causes are to be able to do prevention. And an example of that, and this is actually for epidemiologists, this is standard book example is John Snow. John Snow in 1854, actually there was a cholera outbreak in London, and what he basically did, nobody had an idea what causes cholera because the causal agent was only discovered decades later, but he mapped on a map of London all the cases with cholera, and he then recognized that there was a connection to a water pump on Broad Street, and he convinced the authorities to take the handle of the pump, and that killed, or stopped, it did not kill, it stopped the epidemics. This is something that, of course, applies to many other situations. If you think of the life increase that we have seen in the last century, actually that was due to many non-medical interventions, and actually not in all instances did we fully understand what was underlying that. And some of these are depicted here. Better sanitation. We do not necessarily understand all the mechanisms involved in how better sanitation improves our health, but it does. Better nutrition, but also, how do you call that? Things like seat belts or helmets actually have really contributed quite a bit to the increase in life expectancy and in healthy life expectancy. Of course, also vaccinations, more recently the banning on smoking, also control of hypertension. Actually, it's interesting, if you think of high blood pressure, we now consider high blood pressure a disease, but high blood pressure in itself is actually not really a disease, right? You don't suffer from it. It's only the consequences of high blood pressure, cardiovascular disease, cerebral strokes, that are real classical diseases, but we can intervene on high blood pressure, on hypertension. So by treating this risk factor for later diseases, we actually prevent a lot of diseases. Another important consideration is that multi-causal diseases offer multiple options for intervention. What do I mean with that? A multi-causal disease is basically a disease where many different causes can, either alone or in combination, lead to the occurrence of the disease. And the good thing is that if there are many different causes, there may be also many different handles to intervene on the disease and the consequences. And this is what I think is something that is very helpful in the field of Alzheimer's disease and dementia. And I'll tell you why. Here, on this slide, you see this is different age groups, and this is the risk of developing dementia, and you see that that very much increases with age. That is what we know, right? The older, the higher the risk of developing dementia, and here you see this is dementia in general, and this is Alzheimer's disease. Typically, and this is also what you read in many papers, approximately 2/3 of all dementia is due to Alzheimer's disease. And Alzheimer's disease, if you look in the brain of people with Alzheimer's disease, you see plaques and tangles. Normally you have the normal nerve cells, but in the nerve cells you get, with Alzheimer's disease, you get this accumulation of neurofibrillary tangles. Between the nerve cells you get these amyloid plaques. That is the typical way that people think of what is going on in Alzheimer's disease. 2/3 of all dementia, Alzheimer's disease. I'll tell you a little bit to come to the conclusion that this is actually very simplified and not really true in most of the cases. But let's think a little bit more about the causes. What causes Alzheimer's disease? Well, like with any disease, it can be genes, or it can be other factors, or it can be the interaction between genes and your environmental factors. Well, in Alzheimer's disease, there definitely are genetic causes of the disease. mostly in people who develop the disease at a very early age, early onset Alzheimer's disease. We call these autosomal dominant diseases, where if you have a mutation in your gene, you actually are bound to get the disease. Very rare, but very devastating, of course, for the people and the families involved. But in total, less than 1% of all the people suffering from Alzheimer's disease. There's also several, we call them susceptibility factors. So you have genes who in themselves not necessarily lead, or changes in genes, mutations in genes, who not necessarily lead to Alzheimer's disease, but where actually, if you have that certain variant of a gene, your risk may increase. For example, you may have heard of this, the ApoE4 genotype is such risk gene. People who have a mutation or a variant of a specific variant of that gene have a 3 to 4 times higher risk to develop the disease. But actually, many people, or there are people who have that mutation, or sorry, that variant, I should say, and do not develop the disease. There's many more people who do not have the variant who develop the disease. So all in all, that also plays a role in only, let's say, up to 15 or 20% of all the cases. The majority of all the people suffering from Alzheimer's disease, actually, it's not that clear that a genetic factor plays a major role. We actually think that these other factors, the environmental factors or the non-genetic factors, and possibly in interplay with a genetic background, actually is what drives the disease most. And from these non-genetic factors, and this is now I'm summarizing research from more than 20 years, actually vascular factors are very important in increasing the risk of developing Alzheimer's disease. And that is, this has been based on observations in studies where actually it's clear that people who have vascular disease, for example, atherosclerosis, they have an increased risk of developing the disease, but also people with risk factors, known risk factors for cardiovascular diseases actually have a very similar increased risk of developing Alzheimer's disease. And lifestyle factors that influence a person's risk of vascular disease also in a very similar way influence the risk of developing Alzheimer's disease. And that, of course, if that is indeed the case, is actually quite good news, because with vascular disease, we already have quite some experience that we can not completely ban it, but at least do something about it, right? Just to show you some more data, this is actually a very nice study that was done last century, where, and that showed also this. There were nuns who were followed over their lives and actually were tested each year for their cognitive function, whether they were still mentally healthy or not, and they donated their brain after that to the study. And that study actually was one of the first studies that was able to show that if people had Alzheimer-type changes in their brain, these plaques and tangles that I was talking about before, that then it was not only the amount of Alzheimer changes in the brain, but also whether people had also other pathologies, whether they also had vascular changes in their brain that would determine whether the nun had suffered from dementia during her life. And there are many other studies like that. Actually, this is from another study, but this picture is not that nice, so I summarize it a little bit. This is also a study where they compared brains of people who died without dementia and persons with dementia. And in these circles, these are the different things that were seen in the brains. And actually, this is the proportion of people who had pure Alzheimer pathology in their brain, even though they did not have dementia. And here, this is the proportion, slightly larger, of people who had pure Alzheimer pathology in their brain when they had dementia. That is not what you would expect, right? So there's actually, it's possible to have quite some pathology in the brain without having symptoms. No pathology in the brain was actually only seen with people without dementia. But this part, and this is really a very huge part, this is the people, or these people had multiple pathologies in their brain. So they had Alzheimer kind of changes, but they also had vascular changes. They also had other causes of atrophy. And this is what drives or drove actually the dementia, the clinical symptoms in these people. And that is something that we have seen now in a lot of studies, and I will summarize that in this slide. So basically this is the picture that I showed you before, right? Where we have this simplified idea that 2/3 of all the dementia is due to Alzheimer's disease, but Alzheimer's disease is not the same over the entire lifespan. At a very early age, and that is here, that may be these people who get the disease because of their genetic variations. And they have pure pathology. They have indeed only those plaques and tangles in their brains. This is actually the sort of pathology what has been the basis of many disease models. This is what most of the therapies for Alzheimer's disease are based on. But if we look at this part of the population, there are actually many different causes play a role. This is where we have these multiple changes in the brain. And actually where there's also an overlap with normal behavior. There may be people who have pathology in the brain and still can function normally. Very mixed. And this is, of course, where most of the patients are. And given that this is multi-causal and mixed, actually this may be a part of the whole disease burden where we, with preventive intervention, actually can start postponing onset of disease. So how successful are we in there? Have we already some experiences? Well, thinking of these vascular factors, that they contribute to cognitive decline in dementia. As I said, that came out of many observational studies so far. We and others have considered, well, in recent decades, actually the risk of vascular disease, of cardiovascular disease, of stroke, has gone down because of better treatment of hypertension and other therapies that became available. So if it's true that vascular disease is important for cognitive decline and dementia, then maybe we should see similar trends in the incidence of dementia, right? If it goes down in cardiovascular disease, then maybe it should also go down in dementia. And actually, for a very long time, I've worked in Rotterdam in the Netherlands on a study which is called the Rotterdam study. Here you see the map of Rotterdam. This is the area where we did that study. And the study already started in 1990. And we followed people from age 55 years and over who lived in this area. And we did a lot of examinations and we kept following them. Actually, these are some of our participants. This is from a photo that was taken in the early 1990s for one of the newspapers. And the participants nicely volunteered to model for that picture. And the question, one of the research questions in that study was indeed, who of these people at that time totally healthy will develop dementia and why? And can that be prevented? That was really what motivated that study. And so we followed, and that's here in a sort of picture, we followed 8,000 people from 1990 onwards. And then 10 years later, in 2000, we actually invited another number of people because, of course, some people had died, and we said, well, we still want to have a big number of people that we can follow. So we invited another 4,000 people also of age 55 and older. And so we could then say, hey, now can we start comparing these, right? So if things have changed, if the cardiovascular risk has changed between these two groups, then we should see that in, well, how their profile is. We also made brain scans, so maybe we see also differences in the brains of those people. And we followed them for the risk of dementia, so maybe we also see differences in the risk of dementia. This is basically what we looked at those brain scans. We looked at atrophy and markers of small vessel disease, vascular pathology. And basically, to summarize, yes, we did see quite substantial differences between the cohort from 1990 and from 2000. And of course, we took into account differences in age. So this is comparing people from the same age, but who just lived later, who were exposed to different things during their life. Actually, in the later cohort, we saw that people had more often stopped smoking, which is good. They were more physically active, which is good. They actually had become a bit more obese, which is not so good. They also had more diabetes related, also not so good. They had more hypertension, not so good, but they were much better treated for their hypertension and for their diabetes. And they took more statins, their cholesterol levels were more under control. And actually this later cohort did better than the earlier cohort. And when we looked at their brains looked younger, healthier. We saw less shrinkage of the brains, and we saw less vascular pathology in those brains. And when we compared the risk of developing dementia in those two groups, we actually saw that if you compare people of the same age, that the later cohort had a lower risk to develop dementia. So this is what I said in the beginning, this postponing, this pushing the onset of dementia towards a later age, it seemed that that has occurred indeed in this study, in this group. And we have seen several other studies in Europe, also in the US in recent years, that all point in that same direction. Yes, in the last decades, in at least Western countries, it seems that we have managed to reduce the risk of dementia and Alzheimer's disease and bring the onset to a later age. So this is not to say that people will not get the disease, but they will live longer, healthier until they get the disease, which I think is a major achievement or goal of prevention. The question is, of course, what is the reason behind this? We think that actually the impact on vascular pathology is a major reason, but also probably that people throughout their life were exposed to better education, maybe better healthcare provision. Of course, there's a lot of things that have changed over the last century. There was another way to look at this, because I mean, before we can really start recommendations to treat people for vascular pathology, we want to be sure that that is really a way to go, right? That it would give us the yield that we anticipate. So another way to look at this is, well, if this vascular risk is indeed important, if hypertension, high blood pressure really has an impact on the risk of developing dementia, can we then start treating high blood pressure, and will that have an effect on the risk of developing Alzheimer's disease or dementia? And this is actually done in several of these big randomized clinical trials. They looked at it, and one of the trials, and that is, well, it was the hypertension in the very elderly trial. That was a trial that was not started to look at the effect on dementia. It was actually a trial that was started to look at the risk of stroke and death in very old, no, not very old people, people over the age of 80, I think. And they had to stop that trial because it was already, after just a couple of years, clear that it was a very beneficial to also treat elderly people for their hypertension. But until then, they had 263 patients with dementia. They analyzed the data. Do we see a difference in those who were treated for their blood pressure? Yes or no? They found a non-significant reduction in the risk of 14%. And the conclusion was, well, it's non-significant, no effect. But this is actually, if you look at the data from this study, and I hope that also the people in the back can see it. What we see here, this is the time of the study, the duration, the follow-up, and this is how many people developed dementia during the follow-up. And the people who did not get this intervention, this blood pressure lowering, is this dark blue line, and the people who got the intervention is the light blue line. And you may appreciate that actually the people who got the intervention, there were less people who developed dementia, right? So, and you can sort of say, if these lines, if this study had run longer, maybe these lines would have diverged even further. So what these people did, they actually combined their data with data from other similar studies. And in total, they combined it and then came up with almost or more than 16,000 people who were included in these studies in total, almost 800 new patients with dementia in those studies. And then they found a risk reduction, which was actually similar as they found in the first study, but now it was significant, 13%. Well, you may think, is that important? Maybe a 13% risk reduction does not seem as an enormous risk reduction, right? But it's important to realize that actually in all the big cardiovascular studies, the risk reduction is similar. Only that is because they then know beforehand when they start a study that they can expect only very small or relatively small effects. And so before they start a study, they say, well, we need 15,000, 20,000 people enrolled in the study because we think that the effect is 10 to 15%. At the same time that this study came out, there were two big cardiovascular trials that actually were powered, so they were beforehand planned to find a risk reduction of 13%, precisely what came out of that study. So I think that this is not the final say, but definitely the evidence suggests that we can gain quite something from intervention on cardiovascular risk factors and hypertension. I apologize. I only now see that this slide actually is the German version, but, but I'm sure that I could also make a similar slide with using American newspapers and articles, right? There is almost on a daily basis, there's reports on what we should do or should not do to prevent Alzheimer's disease. And we should not be too fat, and we should eat fish, and dancing is very important, at least according to some studies. And wine is actually also not bad if it's not too much, right? A glass a day, and don't overdo it. Don't stress. Well, the genes we already discussed. Depressions are not good. High blood pressure we already discussed. The most recent trend actually, and we will come to food, but the most recent trend is actually that no food is good for you. So what do we make of that? Well, not of course always no food, right? So they basically recommend just to skip it every now and then. Just by the way, a comment on this, obesity is not good, because I don't know whether that also came in the newspapers here in the US, but earlier this year there was suddenly this report that at least in Europe got a lot of press because there was this study including more than 2 million people that suggested that, in contradiction to what we have heard plenty times over the last couple of years, that obesity is not good for you, suddenly there was this study saying, oh, but obesity in midlife is really very good for you. It protects from dementia. So people were so excited because suddenly they had a good reason not to be demented. But and not to care about being overweight, but I just want to point out something on this slide, and forget about this text, but look at these graphs here below. These 2 million people, or maybe you can look at it, they came from a research database, data that were available there. And there is now, and you also have definitely heard about this, all this big data analysis, right? We should make more use of data that are readily available because they can provide perfect insights into I don't know what. This is actually what these people did. This 2 million people database was an existing database, and they looked into that database. What is the relation between obesity in midlife and later risk of dementia? But if you, and this is the number of people with dementia, or actually the risk of dementia according to age. In red, you see the numbers within the database for women and for men. Here, red, the database. The blue numbers are actually the numbers from very thorough studies assessing how many people develop dementia in the UK. This was data from the UK. So what you see here is actually there's a huge discrepancy between the people that were recognized as developing dementia. And I hope that you understand that actually it may be that this relation that they found between obesity being good for you rather than obesity being bad for you may be because they missed out on more than 2/3 of all the patients who had developed dementia at that time. This is a completely biased observation. And that is actually, with a lot of all the data and reports that come out daily and daily in the press, I think something that we always have to bear in mind, this caveat. Where do the data come from? How robust are they? Have they been reproduced in other studies? And can we really believe them, or is every day a new hype? Food and brain. A lot of focus, of course, on what to eat. Not only if you want, should we be obese or not, but also if we then eat, what can we eat to keep our brain healthy? And many studies, and also many of those reports that we see in the newspapers each day, actually just will focus on some single foods or categories of foods and then say, well, that is good or not good for your brain. Issue is that real life is a bit more complicated than that. It's not just what you put in your mouth, it's also what you put in your mouth gets absorbed by your body, which nutrients get taken out, how are they metabolized, processed in your gut and further body system. And that leads to a nutritional status, and that then actually affects your brain. It's all these steps, and these steps are all influenced by a lot of other factors. It's not only what you eat, it's also what you eat with it. Because what you absorb from certain foods may actually be dependent on what you eat it with. For example, iron in food gets much better absorbed if it's eaten with vitamin C, and not if it's taken with, milk or whatever, right? As any dietist can tell you. Physical activity, if you're active, you have completely different needs for food, and you actually also process your foods differently. Your gut microbiome, you know? All these little creatures living in you. You know that you have more bacteria living in and on you than you have cells in your body, right? Do you know that? That's quite amazing. They have an impact, and they also influence what happens with your food before it gets to your brain. Your whole body composition, your health status, your age, they all influence all these different steps in each other. So if we really want to make specific recommendations on what to eat to keep healthy, actually we have to take this into account, and then I think we can come to very specific, personalized recommendations. And then we make recommendations. And then we tell people, yeah, it's good to eat an apple. But that's not always going to work, right? Children don't eat spinach just because you tell them it's so healthy. And even if they know it's healthy, they may make the, well, not optimal choices always. In the thinking of prevention of dementia, it's also important to realize that actually dementia and Alzheimer's disease develops over a very, very, very long period. We now know that it's not something that happens overnight, right? It's something that actually develops over decades, 20, 30 years. And during 20, 30 years, gradually people may start losing some of their cognitive abilities, or at least brain pathology may starting to accumulate, and even then there is a long trajectory before people really have the full-blown symptoms of dementia. This is, of course, there's so much pathology, this is where more therapeutic intervention focus on, but this is the whole long life period where we actually can work on prevention. And there is, of course, the genes. It's hard to change your genes, but environmental and lifestyle factors that really over a very long period interact with those genes is what we can intervene on. And there, I think cardiovascular factors are important, diet is important, physical activity is important. Basically, you can say what is good for your heart is good for your brain, right? Just 2 or 3 final remarks regarding prevention. One thing, and it's actually with this idea of the preferences, I already alluded a little bit to it, it's that there is no heroism in prevention. And that is actually, I think, a big, big challenge for everybody who really wants to take this serious. And what I mean here is, for example, even for physicians. I mean, a physician will treat a patient, and the patient will be grateful to the physician, and that's the deal, right? I mean, no patient is grateful for preventing a disease that was not even there, right? Big pharma, with hypertension actually, and with all the blood pressure lowering drugs, I think that was a very successful way how pharmaceutical companies got involved to develop therapeutics that really help prevent disease. But that was because hypertension got labeled as a sort of disease. And the FDA and the European counterpart, the EMA, actually recognized, yes, you can develop drugs for that condition, and we will reimburse them. But for normal preventive interventions, actually the FDA, or pharma does not get reimbursed. So there is no economic incentive to develop or to largely invest in preventive interventions. And also for governments. I mean, how do you sort of estimate what is the benefit of prevention? In a way, if you really calculate this through, it may be more costly for a government to promote certain prevention measures than to not do it. I mean, if you really have people living longer, that costs money, right? But there's also for the individual a sort of not so clear benefit, and this is what we call the prevention paradox. And think of this example that I gave with high blood pressure lowering, we had a 13% risk reduction. That is actually for an individual not so much. But given that it applies to 80% of the population, because that is current estimates, that 80% of people have high blood pressure, then, of course, at a societal level, it becomes huge. But that is very hard to then motivate people to change their individual behavior, where the effect is actually much more on the population level. It's the same as with the seatbelts. If you wear your seatbelt, yes or no, it's not directly going to affect your risk, right? But if everybody wears their seatbelts, actually together, we can reduce really many, many accidents, or how is it, what is the word? Injuries in traffic. So, one example of actually a very recent study that at least tried to sort of bring some of those observations from many of these studies into practice is a study done by Mia Kivi-Pelto, where she had an older cohort, people from over the age of 60 till 77. They were at an increased risk of dementia in the sense that they actually had cardiovascular risk factors and so on. And they said, very simple, basically what I also, what happens if we sort of try to optimize the condition of those people? We give them nutritional advice, we give them a training program to be physically active. They get some cognitive challenges, we make them also, we keep them also mentally active, socially engaged, and we very well control their heart and health risk factors. And then they compared that group, 2 years of such a multi-domain intervention, as they called it, with people who just got a regular health advice. And after 2 years, there were already measurable differences in the cognition with the people who got this multi-domain intervention doing better. So I think all in all, this actually really sums up to living healthy is good for your brain. Prevention works. Let's work on it. Thank you.
As a retired epidemiologist, I appreciate the epidemiologic focus. The preventive activities that I think I heard being presented are really identical to the ones you'd use for a healthy lifestyle.
Yep.
Anyway. And I'm wondering whether you think that if we were all to live more healthily and follow all those risk factors, that we would have the same reduction in dementia, in Alzheimer's particularly, as we do in heart disease. It looks like there may be some evidence for that in some of the data that you presented.
Mm-hmm. Yeah, well, there have actually been some people calculating and estimating, like, what could we see happen if we could really effectively intervene on several of these risk factors, right? And then assuming that we could, of course, you can never take them completely out, but if we bring down that risk. And estimations are that indeed we can reduce the risk with 20–30%. And that is extremely substantial. And that's not enough. So I think that also, of course, research has to go on to even look at more specific interventions or preventions. That is actually why we are also now starting up a new study where actually we already start following people from the age of 30 years onwards to really look at what are all the factors that also already at a very early age influence brain health. Because I think that actually brain health at age 30 will be a very strong predictor of brain health at age 50, will be a very strong predictor of brain health at age 80, 90. But yes, already starting with what we know will yield results. And I think that is actually my call that I want to make tonight, right? We already can do something. So that's not to say that we should not need more or have more knowledge, but let's at least act in bring into practice what we already know.
Why aren't universities leading the way to help change the lifestyles of people on an educational platform so that children in elementary school are learning meditation and yoga and food is organic? You know, if we could reduce these factors and if we could help balance these things out, I would like to see it come from the university place, but I don't care where it comes from. I just think we're all being cheated by not starting earlier.
Mm. Yeah, I think your point's well taken. I think I try to allude a little bit to that in the end, right? That it's not, it's easy to agree on that it would be good, but then to bring it into practice is really a challenge. And it's easier to have a big campaign for unhealthy food than have a campaign for healthy food. I'm actually glad to see, at least in recent years, that at least there is a little bit more recognition that, especially in the Alzheimer field, that yes, we should focus more on prevention, not give up on also providing good care to the patients. Of course, that's also what we do, but that should not be prioritized, or actually we need these parallel approaches to really tackle the problem of Alzheimer's disease.
I'm just curious, the lady behind me, who I didn't turn around to look at who it was, but had mentioned organic. Do you think that really makes any difference? I have heard a lot of doctors who don't feel that it does, and occasionally, I know a lot of people do think it does. Mm-hmm. The eating healthy, I understand. The organic, is it really necessary? I've also heard from people that should know that most of the food that we grow now is grown pretty close to organic if it's not organic. Mm. Even those are pretty close to how organic food is grown.
Mm-hmm. Okay. Organic, non-organic, to be honest, that is a bit outside of my knowledge. And I think it's, as you indicated, there's also, I think, a strong feel. It of course also has an emotional component. What I think is extremely important to realize, and this goes a bit to what Charlie said, scientists want always research and data, right? I think what is very clear is that the diet has a huge impact on total health and behavior, and also the changes in our Western diets over the last decades have a huge impact on our health. For example, I think there is, in the area of obesity, there's also increasing evidence and research ongoing that it's maybe not just what people eat, but actually how processed that food is, which may impact on the effects on your body. And that may then not be just because of the foods, but it may actually be because how it affects your microbiome, which completely changes, which affects your immune system, and blah, 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 blah. So I think, oh, there I do, now I do it again, right? Right. But I think everybody understood what I meant, right? Yeah. So it's, I think this complexity of what is real relevant there, I think we have only started to seriously look at that. I think it is very worthwhile to look at it. And I would actually see, is organic or non-organic, are there any differences? What are the differences? I think that is a question worth thorough research. And then we could make funded recommendations.
Hi, first of all, a compliment. I love your Delft Blue PowerPoint.
Thank you. The Dutch note. Huh?
Yes. And then the second thing is you're talking a lot, or everyone's talking a lot about early intervention on brain health, but it looked like from your last study that even making modifications later in life is still effective. Is that correct?
I think so, yes. And this is something that we also see in other interventions, right? It's actually also, of course, it's good if we talk about the vessels to make sure that you keep your vessels healthy from early life onwards, that you start treating your blood pressure if it gets too high very early onwards. I showed you this trial results where it's actually clear that even if you only start treating it over the age of 80, it's helpful. It is never too late to start improving your life. And that's actually also a good message, right?
You've talked about hypertension and diabetes specifically impacting brain health. How about high cholesterol? Does that have similar impacts?
Actually, this is an interesting question because I think that over the years the data there have been rather inconsistent. What is clear is that the whole lipid metabolism is important. I don't, now I look at Charlie, maybe he can save me, but I don't think that besides then what we discussed also, of course, that a high cholesterol has its impact on the whole vascular system, that there is any specific evidence that it might relate to brain health, at least not at this moment through another mechanism, but.
Yeah, actually, so we've done this research, and so the most, but it's new, it's relatively new. So the important point is it, at least in terms of brain health, not of heart health, okay, the absolute value of the total cholesterol, the total measure of the cholesterol, is not related to any risk factor that we can see for Alzheimer's disease. But if you look at that abnormal protein that Monique talked about, the amyloid, that we have found that the bad cholesterol, the LDL cholesterol, the higher it is, the more likely you are in your 70s to have that abnormal protein in your brain. The higher the HDL, the good cholesterol, the less likely you are to have it. And importantly, what we found, and this is a relatively small study, so it's still early days yet, and this is where I'm being conservative. It didn't matter, actually, whether you were on a statin or not, okay? So the important thing is to get that HDL cholesterol up. But we know that that helps your cardiovascular system, and that we know there are many ways to get it besides just simply medications like exercise. Okay?
And actually, in that, and that is right. So actually the HDL may affect the brain not only through the cardiovascular system, but also because it has a direct role in the whole immune response. And there is more and more evidence that also inflammation and innate immunity actually impacts on your risk of neurodegeneration.
Would you comment about atrial fib and brain health and what studies have been done, or what kind of correlation, or what the mechanism is?
Mm-hmm. There have been some observations in the 1990s suggesting a relation between people with atrial fibrillation and having an increased risk. I have seen some more recent data actually that also show that. I think that a possible relation, of course, is that atrial fibrillation increases your risk of stroke, but also of small vessel strokes. So I would think that that is most of the evidence there.
You spoke mostly about prevention, but I was wondering if the things that you said about prevention would also apply to slowing down the disease once you have it. And also, has there been anything in terms of reversal, like cardiovascular disease can be reduced with, like, I think, really low-fat diets, or like the McDougall approach and stuff like that? Is there any evidence for reversal?
There is no evidence for reversal, and I think that for many of these preventive intervention that we are discussing now, that they are really different if you apply them earlier in life or when people already have dementia. Think, for example, of people who have Alzheimer's disease. Their dietary requirements become quite different, right? Because their whole metabolism also changes. So I don't think that we can easily just translate from what you observe in a general population to keep your brain healthy may be different from what to do when there is already some damage or some substantial damage done.
Yes, I'm curious. In the United States, we have a region called the diabetes belt. And I'm curious what the relationship is between A1C and development of dementia. A1C is a measurement of blood sugar over the past 6 months. And if there's a positive relationship with that in any studies.
There have been a lot of studies who actually showed that there is a relation between diabetes and the risk of dementia and Alzheimer's disease. The question is whether this is a causal relationship, and why do I say that? Because there are actually, if it's causal, right, then you would, and we say that dementia develops over decades, then you would actually also expect that people who are at an early age have diabetes, that they decades later would still have that increased risk of developing dementia and Alzheimer's disease. And actually, in the Framingham Heart study that you may have heard of, also in our study in Rotterdam, actually what we saw was that the risk of developing Alzheimer's disease or dementia was actually mostly a relatively short-term risk. So not 20 years later, but definitely in the 5 or 10 years thereafter. So the question, and I think this is partly unsolved, is whether it sort of triggers when there is already additional pathology ongoing, or that it may even be a result, because you can even imagine that if you have advanced brain pathology, that of course also that brain pathology then starts influencing how your whole body, how the metabolism is, what is it? Thank you. For example, actually in Huntington's disease, which is another very specific neurodegenerative disease, there is some suggestion that it's actually the neurodegeneration that precedes the metabolic disturbances. And I think this is, it's a very good question, because I think it's an area where we definitely need more research.
Is there any studies or that show any type of like brain trauma or concussions contributing factor to Alzheimer's?
Well, so it's not, we don't necessarily have to have severe brain trauma. What epidemiologists have done, and I've been part of these studies, is that if you have been knocked unconscious for more than 5 or 10 minutes, so that's relatively severe, then your lifetime risk for dementia is increased. Okay?
Not that much, not in all studies.
And the Rotterdam study didn't show it, but we showed it. So what do you want to say? What we do know for a fact, is that repeated head injury, blunt force to the head, can lead to a dementia that is not Alzheimer's disease, but may look like Alzheimer's disease, and that's chronic traumatic encephalopathy. It used to have the name, I loved it, pugilistic dementia, pugilistic being fighters, okay? And so we've known about this for a long time, but it's now becoming much more, people are much more aware of it than they used to be, because I think what we're beginning to understand is that you don't have to get beaten about the head repeatedly to get it, even though there's some concern that, of course, NFL players are particularly beaten about the head. But the reality is, it's not what's happening to them in the NFL, honestly, okay? Because you think about it, do you know how long the average career in the NFL is?
8 or 9 years?
No. Yeah, 2 to 3 years, yeah, okay? And so you can't, I mean, even if you were, a guard, okay, and you're getting hit over and over, you're still not, it's the 25 years that you got hit, or well, maybe, a lot of these people start when they're 6 or 7 years old, so they've been getting hit in the head for a long time. And so I think that's what the issue is. That said, it's also true that if you get severe head trauma, you can have a progressive neurological disorder that looks like a dementia too. So yes, the answer is yes, and it's not good. Okay? So don't bang your head against the wall. I mean, my wife's been telling me that for years, and I think I'll listen to her now. Yeah.
Would that be the same thing?
The answer is that, yes. And why is that? That's just a measure of severity. Okay? So if you have what we call antegrade or retrograde amnesia, that's just a more severe injury. Okay? So if, most of the time what happens is, particularly in athletics, there's a contact, the person becomes a little woozy for a couple of minutes, gets pulled out of the game, and 10 minutes later they're fine, okay? It's when they can't remember the game that that the entire game, and maybe the trip to the hospital, that it's been more severe.
There is some talk and possibly studies indicating that dirty electricity, electromagnetic frequencies, smart meters will cause hypertension, AFib, even diabetes, which would then indicate that would probably affect Alzheimer's as an increase. And now that we're all getting smart meters and we all have a satellite and we all have a cell phone, are you seeing that, or are there any studies where they're checking that out?
There have been studies. I have not seen convincing evidence to support it.
When you had these studies done, were there any cross-references for the women in the studies, because age is one factor, that were premenopausal as opposed to postmenopausal? And in terms of hormone levels for the men who were in the studies, some being younger because their testosterone level was that more of a younger man or that of an older man. Was there any cross-reference or any differences that were found?
There have definitely been studies looking at, hormone levels, actually age of menopause and risk of dementia. I don't think that there is a very consistent or clear summary from that. I think this is also an area where actually the stakes are still open, where it is not clear to say, okay, this is absolute how that association is. So I would think that, again, this is an area where it makes sense to look into that. Actually, there is evidence more and more that this may be a no-brainer for you, but men and women are different. This is really on a lot of fundamental biological mechanisms, because for a very long time, actually people only looked at indeed hormone levels, whether they were different or so, but actually a lot of processes, and also, for example, even recovery after stroke or whatever, is different between men and women. So this whole gender-specific research is actually only recently being taken off more seriously. And not only at the observational level, but actually also in fundamental research, because also in animal research, where for a long time they only did research with male animals, because then you did not have the problem with the oestrus of these female animals. Now they start looking at also female animals, and guess what? It's different. So I think this is a very appropriate question, but we don't have the right answers there yet.